Welcome back to the Chatty Vets Pod. I'm Brendan.
I'm Charlotte. Thank you for tuning in.
Welcome to our third podcast of June, our next 2-week Takedown episode.
Yeah, this is where we aim to bring you up to date with all the latest news and products in the UK from the last few weeks. Just a reminder, this podcast is intended for veterinary professionals and veterinary practice staff, including vets, vet nurses, practice managers, reception teams, and students working in the veterinary field.
Yes, welcome to you all. We've got another really good show for you today. We're going to be discussing loads today, from new research into urethral obstruction in cats, regurgitation risk in BOAS, and, God, that sounds really dry, dental antimicrobial stewardship. Everyone gets so animated, don't they, on the social media? But the exciting part, we've got another guest on the show too.
Yes, we do. So we have the amazing Bradley VINER as our special guest today. We are amazed that he actually agreed to come on the podcast with us, but we can't wait for you to hear our interview with him. I have to admit though, Brendan, you actually introduced me to him. I didn't have much knowledge about Bradley previously, but he's really interesting actually when you get to talk to him.
We did, yeah. Do you know what? I feel like the Chatty Vets owes a little bit of its origin story to Bradley VINER, because he was one of the key people that was really trying to say that being a GP vet was a specialism in itself and just as valid, just as difficult, took just as long, if not longer, to be really good at. And it's not just being a GP vet. You're not just a vet that didn't specialise. You actually, if you're an experienced and good GP vet, you've got a whole host of really good skills to give. And that's what the Chatty Vets is a bit about. It's, you know, being a good GP vet is a multidisciplinary and complex thing.
Yeah, absolutely. So keep listening to hear us catch up with Bradley later on in the episode to talk about why we should never be calling ourselves just a GP vet, along with talking about some disciplinary processes in vet med, and maybe why we don't need to be as scared about it as we're all sort of led to believe.
Yes, he is the man in charge of disciplinaries. So we're looking forward to it. But let's start with something light-hearted, but something that's been bugging me forever, and that I find truly disgusting. I hate this. Right, everyone in the UK, take a good look at the mirror, because you're all filthy. Every one of you is out there putting a syringe with its needle cap and put the needle cap in your mouth. Can everyone out there stop it? Because I think it's disgusting. I don't do it. Well, there's one exception, but otherwise I never, ever do it. Stop it. That's it.
Yeah,
done.
I
Finished.
do this all the time.
Everyone, it's disgusting.
Yeah,
and I don't want to fall out
time.
with everyone. So
Yeah.
most of the time I just internalize my seething anger. But why is it only me? It's filthy.
Yeah, I need to stop doing this as well, because it's definitely shot me in the foot a couple of times as well. Because it is habit. Like, I'm busy with my hands, so I use my mouth to pull the cap off, which is so bad. I know it's disgusting, but anyway, and it's caught me a couple of times, because like if I've been doing a euthanasia and I've had the syringe and the needle in my pocket and I've taken the cap off, but I've not realised that I've accidentally pressed the plunger a little bit while it's been in my pocket, so I've ended up with like pentabarb in my mouth, which is not great. So yeah, I think I need to stop doing that. It's really bad.
I think I might have mentioned this when I was newly graduated. I sprayed a client in the face with pentabarb.
No.
Really badly as well. Like, it showered us both, because someone had taught me about using an extension set and getting further away from the animal. But I think I had it either locked off or blocked or something. So I was squirting it in and it all just sprayed back at both of us. And the lady was like, I guess it's not that dangerous to get it in your face. And I was like, no, it's not.
I've done it before, where I've been putting an animal to sleep, and the people were so emotional. And you know, when you've got like a little clot in your, because I don't think I had a bung on it. I think I'd screwed the syringe straight into the IV and was trying to push it, and it just wasn't pumping. So I put a little bit of pressure on, and obviously I hadn't like pushed it in quite far enough, and it just squirted right back at me, but it went in my eye. So I was there like one-eyed, being like, everything's fine, trying to put this animal to sleep. And I was like, I'll just give you a minute. And then I had to run out and go wash my eye. So yeah, I think we've all probably had cases like that. But yes, I do desperately need to stop putting the needle cap in my mouth. It's a bit disgusting, but I think everyone does it, don't they? It's just I'm so used to it.
Everyone. It's ridiculous.
Such a bad
do you know
habit.
What? People are so ridiculous about it, because when I started as a vet, it was really common to leave sharps lying around. So you'd go into a concert and there'd literally be needles, blades, everything just all littered around the worktops. I think that stopped.
Yeah.
And people would be like, You leave sharps lying around? What a terrible person. But yet everyone puts their MRSA containing mouth onto a needle cap. And then what they do is they get their fingers and they get the needle cap, which has now got their MRSA from their mouth on it. And so they get that on their hand. And then everything is now being covered with their mouth juice, which is what, a 1 in 10 chance of MRSA going everywhere? Like, come on, people.
Yeah.
Come on. This is not right.
Yeah.
That's it, Charlotte. Make an oath with me today.
Okay,
No
okay.
more needle caps in your mouth.
Yeah. Okay. It's a habit of a lifetime. I need to break it. It's bad. And that's exactly what it is. It's habit. I don't even realize I'm doing it. It's bad.
Anyway, that's that. But we're going to come back to this. If I still see it carrying on, we're coming back to it every episode until it stops.
Okay. All right. Moving on to something a bit
Sorry.
less
Did I get a bit
argumentative.
angry then?
You did, but it's okay. Okay. Moving on. Brendan, you wanted to have a chat about a little surgery case that you had recently.
My God. Just, you know how there's so much stress in our life, isn't there? God, I need to calm down about the needle cap thing. Hold on, let me just take a breath. Right, okay. So I've been trying to make my bitch spay incisions a bit smaller because, you know, like everything's a bit new to me because I was out of GP for 4 or 5 years. Now I'm back trying to. So I had a German Shepherd and I got a really lovely little incision, did the ovaries, which is a bit of a pain actually, but I got them done. And then doing what I perceive as the easy bit, I think what I'd done is because it's a smaller incision, I was pulling the cervix quite hard and far round to get it exteriorized. So when I put my ligature on, I think it might have been under a bit of tension and it's like bent around your skin, if you like, you know, as it's coming from caudally and it's coming cranially and then caudally again as you bend it round. And I could almost tell when I tightened it, it kind of swelled. It's weird, actually. It kind of swelled up a little bit. And I kind of cut it and thought, well, look, it's a damn good, you know, it's my usual, it's really good suture, ligature. And I got my forceps and I started to let it into the abdomen. And I could just almost tell it was like moving or changing or something. And I could just see, and I literally, as I went further in, I could just see the knot slip. Now, foolishly, I had it in my forceps, but for some foolish reason I can't explain, I just let it go. I don't know why. And it went bing, because it was under tension. It just went bing into the caudal abdomen. And I was like, it's going to be bad. And you know when the blood's coming up really quick.
Yeah.
So I just like, right, make the incision bigger, which I was like slightly gutted because the whole point was the small incision.
Yeah.
Opened it up. Lap swab. The nurse was obviously, this is when you're nursing, you realize how good your nursing team is. Like, lap swab, da da da. And then she was like getting everything done. And I got my lap swab, whacked it down there. And then, you know, you pull things slowly, like you slowly like retract your lap swab like in one direction, letting a few things out until you see something wiggling around with loads of blood shooting out of it. So it didn't take me too long, but the blood was coming proper fast. Yeah. And then got my ligatures on and done it.
I don't know. Well, like, why are people bothered about small incisions? Why are you bothered about a small incision? Why does it make any difference? They heal side to side, not end to end. This has always been my gripe. I don't get the point of making them small. It just makes your life so much harder. It's more risky for the patient, like you've literally just explained. I don't get any pride by thinking, oh, that's quite small, that incision. I get pride by doing, I've done a fairly decent incision. I know I've checked that whole abdomen. I'm happy because I can see everything. And I don't know. I don't get it. I mean, but I might be the minority here.
I don't think you're going to get around the perception from the client that their patient has had somehow more trauma. Look, you just take it to its logical extreme. If you have a 1 centimeter incision, you know, or lap spay, for example, or a 3 inch or 4, whatever, the client is going to go, oh, they've had a bigger surgery. Because that's the bit they can see, aren't they? It's going to be hard.
But I mean, I think it's the out of hours vet in me is like, I'd just rather make it bigger and make sure I'm happy. I had one a few weeks ago. I had a bitch spay that had bled post spay and she came in that night. I scanned her and she had quite a lot of free abdominal fluid. I did her coags and stuff and was like, no, it's not a coagulopathy. She's definitely bleeding from a ligature. And honestly, I extended her incision massively because again, hers was really neat and teeny tiny. And it's one of those things, it happens. They slip. Even the best surgeons can, you know, it can happen. But my God, was there a lot of blood in that abdomen? Like, my God. And top tip as well, if you ever have to open one back up that is bleeding, best thing you can do, get you know those blood bags that you can get from Pet Blood Bank that have the CPDA one in them that you can use to collect blood from your canine blood donors? if you get a bag, get someone to give it sterilely to you in theatre and get them to give you sterile 20 ml syringes, then what you can do is draw up 3 mils of the CPDA1 into each of those 20 ml syringes, and then literally suck the blood that's being pumped out of the abdomen into the syringes, give it to your nurse and auto-transfuse it straight back in. Do it through a hemonate filter, like, you know, those little circular filters that you stick on the end of the IV so that you don't get clots or anything in there. But basically, if you do that, one, you're not going to get so much blood loss because you're putting it back in. But two, it means that because you're either going to have to suction it out of the way or use syringes. So why not use syringes to put it straight back in? Because when I opened her up, her blood pressure dropped and her MAP was 52. So I backed the ISO down, turned her fluids rate right up. As soon as we started auto transfusing her, she was fine. And she woke up absolutely fine. But yeah, they can be quite scary. And I think that's it. Once you've dealt with a few that have gone wrong, like now, I just never make a tiny incision because I don't know, I'd rather make sure that I'm happy.
Yeah, can't you? Because you want the filter, obviously. So I've tended to kind of try and put it back into the bag, I think. But is it because you might not get the volume right? It's all of this kind of issue.
Yeah, because I think you worry about if you have too much anticoagulant per bit of blood. So those blood bags are made for if you're putting 400, 450 mil of canine blood into them. So if you're only getting, like, that dog will be transfused 130 mil of her own blood. And obviously I would have had only a quarter of the blood that should have been to that ratio of anticoagulant. So if you use only 3 mils per 20 mil syringe, then you know you've got the right ratio.
Because there is a point where the blood in the abdomen is it defibrinized or something?
Yeah, if you know,
how long do you have to wait for that?
an hour. So if you know that the blood that's been sitting in the abdomen has been there for longer than an hour, you don't need to use anticoagulant. But the thing is with an active bleed, some of it will have been there longer, but some of it is pumping out as you speak. So it's, if in doubt, then just use the anticoagulant. It doesn't cost that much more. And I just think, well, at least you're safe then, you're being sure.
I was going to say, before I forget, having worked in a lungworm area, the coags are normal, but they've got a bleeding problem, haven't they? So it's not completely ruled out.
No.
Until you've done a lungworm test.
I think the only thing that changed that for me is that I didn't do a snap because she was on the worm that treats for lungworm monthly. So I was like, well, the likelihood of her actually having an active lungworm infection is really minimal. So, but yeah, I mean, if you do ever get in there, if there's no ligatures that have slipped, she's bleeding from everywhere, not just from somewhere, then yeah, absolutely. In an ideal world, do your coags, make sure your platelet count is okay, and do a lungworm snap. And if all of that comes back negative, then I'd go into theatre. Because it's always the way as well. As soon as I opened her abdomen, I relieved the pressure and it was like, whoa, here comes the blood. But before then, she'd been kind of okay.
I did something you taught me the other day, the ketamine, intraoperative ketamine. So I had something under anaesthetic for a dental, very long dental. It was a cat. It's a cat. It's proper. And the mean was dropping to maybe just under 60. So I did I got the nurse to draw up 1 mg per kg ketamine. And I said, let's just give half of it as a little mini bolus and see what happens.
Yeah.
And it was really good.
Yeah.
Got the isoflow down a bit, got the blood pressure. I think the ketamine itself, kind of blood pressure went up. And do you remember when we had a chat with our secret special guest that's super amazing? And he said that you get some respiratory apnea when you use intraoperative ketamine. Don't you remember this?
Yeah.
And no one on social media had really pointed this out.
Yeah.
We did get a little bit.
Yeah.
So even on that little half dose, it wasn't terrible, like the nurse, but the rest definitely went back a bit. And then 30 minutes later, we did the rest of it because it's starting to creep lower again. So it was very cool. I love the ketamine.
Really good. Yeah, it's so good. I mean, I tend to use, I think it's 0.25 mg per kg as my first bolus, because I feel like if you give 0.25 mg per kg, I don't appreciate the apnea quite as much. And then if it's not quite done enough, then 5-10 minutes later I give the other 0.25, so it makes up to half a mg per kg. But then I feel like if I split it, I don't get quite as much apnea. But it's anecdotal. But
so I could draw my 1 mg per kg up because it makes the maths easy, and then just give it in quarters as well, I suppose.
Yeah. Just give it as you need.
Dilute it. Yeah. Cool.
So it works quite nicely.
Love it. Love the
there we go.
ketamine.
There we go.
Had a nice recovery as well. Cat did really well.
And somebody asked you on social media actually about this. I think I'll just reply on here rather than on socials. But there was a question about whether you need to wait till the medetomidine has been in the system for a certain amount of time. To be completely honest, I'm only ever giving the ketamine in a surgery where it's going to take me roughly that long anyway. It's normally in bitch spays, which, I mean, don't get me wrong, some people are stupidly quick and will be in and out in 10-15 minutes, which is, I just find mental anyway. But yeah, I mean, if you think generally by the time you're first cutting and they're getting a bit uncomfortable, if you give that small dose of ketamine, usually by the time you're coming round to reverse, it's at least half hour, 40 minutes later anyway. Um, and to be honest, I don't tend to reverse a lot of my anesthetics anyway. I just find that I tend to leave them without Atipam and they recover really nicely. So it's up to you. I would give it a bit of time, but I wouldn't necessarily be using ketamine in a procedure I think is only going to take 10 minutes anyway. So that's probably what
Then
I'd say
if
about it.
I think it's quite low doses, isn't it? But
Yeah.
if you did feel the ketamine's giving you something, then you just have to go in with your post-op meditomidine, just
Yeah, just
super
a
low
really low
doses.
dose. Yeah. Moving on from anesthetics and surgeries, you know how most of us in vet med are always so bloody busy. We feel like we don't get time to breathe at work. And then because you work such long hours, you feel like you don't get enough time off. And you sort of, it can sometimes be a real struggle to balance work-life balance, breaks at work, etc. But you found something in the news about this fairly recently, didn't you, Brendan?
Yes, it was the Daily Mail. Let me say this properly. Vet wins £12,000 payout because she was forced to work through her lunch breaks. Which everyone's going to have an opinion on this one, aren't they? And I think it's polarized people. I think the tribunal was concerned that this vet was burnt out, and effectively they described it as a constructive dismissal because of the way many things, amongst which was the fact that she didn't have lunch breaks, was unpaid overtime, and then the management was kind of found to be a bit lacking.
Did they lose their job?
She was signed off with work-related stress,
Okay.
and then I think she didn't get much support when she came back to work. And I don't know how it all kind of went after that. Maybe she then just felt really unhappy about working there. I don't know. But I think essentially, yeah. So she was, it was an employment tribunal. So, and
Yeah.
she won damages. So
Yeah,
I
good.
assume yes, but I don't know.
Yeah. I mean, the thing
Yeah.
is it's a bit obviously we won't go into that person's case anymore because it's not fair to talk about one person, I guess, is it? But like it is so true, isn't it? All of us are expected to just work, work, work. And hopefully you're at a place where is really supported and that they will be like, have you had a break yet? Go and grab 10 minutes, even if you can't have a full lunch break. Because I mean, don't get me wrong, if you've got like 5 things dying, you can't just be like, sorry, I'm off for my hour. It has to be a little bit more flexible than that. But you should be working somewhere that's supporting you and saying, yesterday you had a mental day, take a little bit longer for lunch today and being flexible with you. But again, I think I've said it on the pods before. I think unpaid overtime is inexcusable. I hate it. I just think it's your time, it's your work, it's your life. You should be being paid for it. It's tricky, isn't it? And I think every practice will have a different way of doing things. But yeah, someone that feels that burnt out, there's obviously something that's not being managed quite right in the practice for it to get to that point. So
That's easily said, but in reality, it's really difficult because there's people like me that are just, well, there's very few people like me actually. But anyway, I spend far too long doing my consults, obviously. And then, I could easily, if I started to say, want to claim unpaid overtime, my boss would be completely correct to say, well, you're not very efficient, are you? You don't have to be chatting on for 50 minutes to one consult.
yeah,
Yeah.
but I think there's a difference between staying 15, 20 minutes because you know you've been chatting to a client for ages versus having a surgery that comes in that needs emergency surgery that night and your practice policy is
Yeah.
we stabilize everything, treat everything when it comes through the door and then send to out of hours. If that's the way that you're expected to work, then which I think is right, then you shouldn't be expected to stay and do a pyo surgery for like 3 hours post when you're supposed to finish and not be paid for it. So there's a line, isn't there? Definitely, and I think it is a little bit give and take.
It is a grey area. I think the point is it's a grey area, like you say, because
Mm.
there's things which you're making money for the practice, and if you see some of that money back because it's unpaid overtime after work, but lunch breaks. No, that's a real difference between nurses and vets here as well, and how your
Mm.
contract is set up. Because some contracts you're not paid for your lunch break, and if you're not paid for your
Yeah,
lunch break, I think people feel more entitled to say, "That's my lunch break. Thank you. I'm going to have it. I'm not paid for it."
yeah.
Which this not being paid for your lunch break, which is I think corporate world has tried to suggest is a normal thing.
I've never signed a contract where I've had that. I don't think if you're working 8, 10 hour shifts, it's expected that you're going to have a break at some point. I think it's crazy to think that you shouldn't get paid to have a bit of a rest. So
A lot, yeah. A lot of people
because you,
don't. A lot of people have an
yeah,
unpaid lunch break. But what the hell can you do with it? Like, it's not like you're going to go and
yeah.
have fun for an hour, is it? You're in your practice.
Yeah,
It's
exactly. And especially
nuts.
if you work somewhere where you're sole charge, you can't leave because if someone comes in with something that's dying and you're like, see ya, I'm just going down the road to get some lunch. I don't know what the right answer is, but I don't think it's ideal, to be honest with you. One thing we wanted to talk about before we move on to something that's maybe a bit more clinical. You've said this to me recently. Do people call you in practice? Do they call you Brendan or do they call you Dr. Brendan?
I'm so interested that, well, I'm Brendan where I am now, but I'm
Yeah.
so interested. You now work somewhere where are you a Dr. Charlotte?
Yeah, but I don't like it. I find it really
Yeah,
weird. I felt it's like too formal. I don't like it. I'm just like, hi, I'm Charlotte. I don't know.
yeah.
Like I always explain like, oh, I'm the vet that's on shift tonight or whatever. I'll introduce myself as the vet. I think that's the way I consult as well. I consult in a very friendly way. It's like I'm having a chat to anyone. Whereas I think if I was more of a like stern-faced vet, I'd be like, hi, I'm Dr. Charlotte. I think you can still be professional, but still be down to earth.
It's a really good topic, actually, because I did work at another clinic where all the vets, well, there's only two of us, but we were Dr. Brendan and Dr. Dan, actually. And I suppose they're trying to say, look, we should be looked up to. We should be trusted. We're qualified.
Mm,
This is our, it's kind of trying to speak of something.
mm,
But then the clinic I'm in now has huge respect for the head vet. The clients all really respect him.
mm.
And he is just given his name,
Mm.
not doctor. So I don't know what's right or wrong there.
Yeah, I quite like personally for me when we say there's RVNs, there's ACCAs, there's vets, there's everyone in the practice team, and there's no hierarchy, right? Everybody has their jobs, they have their own thing that's what they're very good at. That's what they were trained for. We all do very different jobs, but we work together as a team. I feel like if you call your vets doctor and their name, and then your nurses just their name, it looks like that hierarchy thing, which I don't like. I think that's partly why I don't like it, because I just think, well, like so many cases where I've dealt with that I've thought if I didn't have that amazing nurse with me, that dog wouldn't be alive now. It's just part of that mutual respect. But that doesn't mean that the practices that do use the doctor are doing it wrong, because they're equally trying to get better respect for their vets and sort of saying, we've earned this title, like we should be being able to be called doctor.
Do you know, as you're saying that, you're right, because when I'm going to hospitals and seeing medical doctors, whether they're a doctor or whether they're a experienced nurse practitioner or whatever, it's how they come across and what they say that
Yeah.
is going to make me respect them. I am literally not going to respect the person who's called Doctor something if the content of what he says and how he comes across or she
Mm,
comes across isn't that good. It just
yeah.
means nothing to me. In fact,
Yeah.
so yeah, maybe how far do you really get with that if you can't? I think we are mostly judged by how we come across and what we say, aren't we?
Yeah, yeah. I don't know. But I
Oh.
mean, yeah, definitely message in and let us know what your practice does and why you do it that way. Because it's really interesting to hear the sort of trail of thought behind it. Because I get it. I don't think it's a bad thing. And I think it's quite a professional way to come across. But there's some other things about it that just make me think, oh, I don't know if it's my preference. But yeah, I don't know.
Now, Charlotte, you've come across there's a couple of papers you've come across you thought might be quite interesting.
When we were sort of having a look at what to cover in today's pod, I actually came across a few articles that have been released recently. So some of them are papers, some of them are like systematic reviews. It's very relevant, and I promise you it's not too dry. So bear with us. But there's a couple of things that I just wanted to bring up because I feel like it's something that's really relevant to GP practice. So there's one paper that came out recently that was talking about BOAS surgery patients and trying to reduce regurg risk, which I think is, even though, yes, in general practice, we're not going to be doing BOAS surgeries every day, or not every GP vet will be, but we do a lot of brachycephalic surgery, regardless of what the surgery is. We do a lot of surgeries on our brachies, and regurgitation, aspiration, pneumonia is always something that we're a bit worried about. And there was actually a review that looked at a few papers that was looking at whether metoclopramide CRIs or metoclop use in general would help reduce the risk of regurg in brachy patients. Because I think it makes sense, and a lot of people might be using it sort of preemptively to think it might help. But actually, the study kind of came back and said that there's no evidence to say that it helps at all. So, I mean, don't get me wrong, it wasn't like a randomized control trial or anything like that. But looking at the evidence that's actually out there at the moment, there's nothing really to say that metoclop is going to make any difference whatsoever. And interestingly, when I actually looked this up, loads of people will give meropitant pre-op to their brackies as well. There's actually no evidence out there that that makes any difference either. So I think people that are doing that preemptively, it might not make any difference, which makes sense because if it's regurg, not vomiting, then obviously it's probably not going to help. But have you ever heard of using lignocaine and phenylephrine spray in these guys? Have you ever heard of this?
No, I was going to go back to what you were saying there about the metoclopramide and meropitant, though, because I would have thought when you do out of hours work, we talked about a bit about this in the vomiting podcast, probably.
Yeah.
Where they're on meropitant and they're regurging from their esophagitis, or some of them just got a really weak cardiac sphincter, and the meropitant has no effect on that, does it?
Yeah,
So I
no,
think
not at
we
all.
kind of know that the meropitant
Yeah.
doesn't. It's working in the brain on the CTZ zone, isn't it? So yeah, it doesn't seem to affect regurg. And I think I remember chatting to an anaesthetist about 5-6 years ago who said that metoclopramide at really high doses might have a little bit better chance of helping with regurg. But at that point, you're starting to run into adverse effects from the metoclopramide. So yeah, it's a pain. In terms of the no, I've never heard of lignocaine and phenylephrine together.
Yeah.
No.
So basically I looked into it a little bit because I thought, well, if papers are now out there saying that metoclopramide and meropitant, which we kind of knew already, but if there's papers out there to say that it actually doesn't help, then yeah, we know that we're probably all using a omeprazole or another proton pump inhibitor to help with these cases beforehand. But what else can we actually do to try and prevent aspiration risks? And there was a paper, it was a randomized control trial. It was Feb 2026 that the paper came out. So they had about 49 dogs that had intraoral lignocaine and phenylephrine spray. And basically, post-op regurgitation was significantly higher in the placebo group compared to the lignocaine group. So basically, they found that it actually works, and it's one of the things that they can give that makes regurgitation way less likely. So it's just interesting. So if anybody in practice is doing any surgery on a brachy where they're really worried about regurg during surgery, then apparently giving this combination of drugs can really work. So
hold on, just run that by me. So did they compare lignocaine and what is this phenylephrine?
I don't know.
I mean, is it that made the difference?
So they had intraoral lignocaine and phenylephrine spray, whereas some of them had placebo spray. So I don't mean they're comparing the two different ones, but they're comparing.
And what's going on? What's the mechanism? That's mad, isn't it?
I think it's to do with vasoconstriction in that area. I think. Have a little look at that paper. I think it was Graham et al. In Feb 2026. But yeah, have a little look at the paper and read into it a bit more. So I didn't want to go into it too much, but it's just quite interesting.
I'm going to get all nerdy now because I've got to look. I've got to see this. So would this be much better than just lidocaine spray? Because that's the thing, isn't it? Because we're all doing. Well, actually, we're not doing. No, we're not.
No, we're not.
Idiots. We're not all doing lidocaine spray. It's dogs.
Yeah. So I don't know.
So then we should all.
Well, see, this is the thing.
We need to know this
because they've only done lignocaine and phenylephrine together. It might be interesting to have a study done where it is just the lidocaine spray that we all have loads of access to, because if that maybe is the thing, but then maybe it's because they use the phenylephrine as the vasoconstrictor part of it, because the lidocaine is going to help with the local regional anesthesia. Maybe they use the phenylephrine as the vasoconstrictor and it's the two of them together that work. But yeah, if anybody does either routinely use it or does something different, like for example, just uses a lidocaine spray and finds it helps, and yeah, it'd be interesting to know. I just think it's quite cool because at the moment people are using, I don't know, meropitant or metoclop thinking we feel like we're giving something we don't think it's going to really help, but there's potentially something that can really help reduce that regurg risk. So it's quite cool, really.
Yeah, okay, yeah. I'm just kind of looking it up now, and it says ENT surgeons commonly use topical vasoconstrictors because they reduce mucosal bleeding. So when you're saying vasoconstriction, I was like, but why? But that's one of them? It's for the effect on bleeding? I mean, do you spray it around the place? Because I mean, obviously you spray it on the larynx, but if you're doing BOAS surgery, are they?
I mean, I'm not clever enough to be doing any research, so anybody that understands exactly why and how it works, then let us know. Because if it's something that's been proven to help, regardless of exactly how it helps, if it's not causing any risk to the patient and we can give a quick intraoral spray at the beginning of surgery, then why the hell not?
It could be coming our way. The one thing that is helpful, and it's not just the aspiration pneumonia, it's also the esophagitis, which I think is the PPIs, which some people give for the days before and after the surgery if they're organised. Is that? I think I've seen people do that. Obviously, we're doing IV omeprazole and then post-op 1 week of omeprazole usually.
It depends on your practice protocol, doesn't it? I think if it's an elective that you can sort of talk to them about it in advance. And I think for your brackies, and some people, do it a couple of days before surgery, and then we'll do it intra-op and send them home with some as well. Because I think it take a couple of days for omeprazole to reach its like peak state anyway. Whereas if it's obviously like an emergency procedure, then I feel like IV omeprazole is probably your best way to go. But it's basically just to do a change in the pH of the gastric fluid, isn't it? That's the whole point of it. So to reduce that esophagitis. But interestingly, we had I don't know if it was part of my cert, I can't remember, but we had a lecture a little while ago, and it was talking about how omeprazole is great in terms of increasing the gastric pH in terms of esophagitis, but you do need to be careful, because if you've been giving omeprazole and then the patient aspirates, usually the aspiration pneumonia tends to be worse because the microflora of the stomach is
No.
changed. Yeah, apparently. But it's not a reason not to give omeprazole. I'm not saying that, but it's just worth knowing, because obviously if your gastric pH changes, then the microflora of your stomach is going to change, which means that the stuff that then gets inhaled is going to potentially be a bit worse than it would have been otherwise, because you've got different bacteria that are being inhaled than you would have had if you hadn't have used omeprazole. So there we go.
Mind-boggling. But
Yeah.
I think I feel like, because we did so many post-op complications when I was doing out of hours work, I just feel like the esophagitis is so common. And the problem
Yeah.
is, once they've got that, they don't eat, you can't get oral meds in, and essentially you need hospitalizing until they're better, which is quite a few days sometimes.
Yeah.
And so it makes the whole thing worse. So I do think that part of it needs attention. The aspiration pneumonias are a mixed bag, aren't they? Some of them, you start the IV antibiotics, you do everything, they go quite well. I've had the odd one, I'd say 1 in 10, that they just go into overwhelming sepsis in 12 to 24 hours and there is no coming back. I don't know if you've had one of those. I've had a few.
Yeah, I think the only really bad ones I've had have been when you've got aspiration pneumonia secondary to something else horrible going on. I don't think I've ever had one where it's just aspirated and the aspiration is the only thing that's kicked it over the edge. Generally, they're pretty poorly anyway. So it's whether it's a combination of everything that makes them that bad, or whether it is the aspiration pneumonia that tips them over. But yeah, it's sometimes not very nice. Did I ever tell you about that esophageal foreign body that I had, that I didn't know it was esophageal until it was in theatre?
Yes.
Honestly, that one had really nasty aspiration pneumonia afterwards, obviously, because it had horrendous esophagitis and it had been regurging solidly for about 3 days. But it was fine. It did really well in the end. But yeah, they can be not very nice cases. Their chest can sound bloody horrible. So yeah, there we go.
They're really good. If you're ever unsure if they've had the aspiration pneumonia, you put the ultrasound on their lobes and you can see like quite epic levels of B-lines. But sometimes you can hear it when it's really bad.
Yeah. Yeah.
Did you know the voice in your head of a boss or someone who, that gave you like really effective words of advice? I don't know. There's quite a few times in my head I hear the voice but I've got one relating to this, and the voice is, it's actually Dr. Dan, and I had this obstructed CAC with the FB obstruction, and it had a big bloated stomach full of fluid, and he was like, be careful that it doesn't regurg on induction and aspirate. And we're all fuzzy flying around, and obviously I didn't properly listen. And then I inducted it, and it was like epic levels of fluid coming out of this cat's stomach on induction. It's really at that point, isn't it? You do the induction, and I think I might have intubated it, and it's like bam, bam, fluid. I was like, oh, yeah, that was the voice. But and then now every time I have an obstructed GI case, I hear that voice. Oh, I just imagine it in my head. It's like, be aware of the regurg when you induce.
Yeah.
And like, if everyone has that voice in their head, because I guess you've got to get a stomach tube down into the stomach and empty the stomach, haven't you?
Yeah, I would do. Or if it's that bad, then I'd put an NG tube in first, even before you anaesthetize it. Try and drain as much as you can, and then go for it. But just be careful, because it will make your electrolytes go a bit haywire. But yeah, there we go. So have a little think, see whether it might change your BOAS patients or your brachy patients, what you might do with them. So there we go.
Yeah. And don't get too freaked out, because it looks bloody awful, but actually they usually go quite well, don't they?
Yeah. I never realised this, but so obviously we see block cats all the time, and you would have thought that there's loads and loads of research out there, but actually the studies that have been done on block cats, there's not actually that many that are like big multicentric ones with loads and loads of patients. So there was a new study that came out and looked at 601 male cats, so loads of them, and was looking at what the recurrence risk was and how azotemic they get and what their recovery is like, etc. And I think it kind of came out with what we all sort of anecdotally know, but it's just really interesting to have a paper that actually says it and lays it down on paper, so we've got figures that we can say to owners. So generally they found from this study, cats are less likely to present azotemic if they have a recurrent blocked bladder. So if they've had them before and then they come into you blocked, they're much less likely to be azotemic. But I don't know whether that's because the owners are just more looking out for it. So as soon as they start straining, they're like, yeah, cool, let's get it to the vet. Whereas otherwise they're just like, they don't seem right. And then you get there and their potassium's like 9 and they're collapsed and you're like, oh, it's probably been like this for like 2 days. Okay. Most cats, the azotemia resolves within 48 hours, the majority of them. So, and that's sometimes even if the azotemia is absolutely gigantic. So again, that gives us a bit of evidence behind us to be saying, I've had some that have come in and their creatinine's been like 1100 and I'm like, it'll be all right, give it some time. But I think especially in GP world, if you see a massive azotemia like that, a lot of people go, oh my God, it's in renal failure, it's going to die. But actually, once you relieve the obstruction, they can do really, really well. And they actually said that there was no difference in catheterization and hospitalization duration between cats with their first ever blocked bladder and recurrent blocked bladders, which is quite interesting, I thought, because you'd expect maybe if they're recurrent, that they might end up having to be in for a bit longer because of, I don't know, chronic bladder issues, etc. But yeah, I just thought it was quite interesting.
I'm back in general practice, a year and a half? I've only had a handful, but they're like in
Yeah.
every week, aren't they, out of hours?
Yeah.
Yeah. I've still got really fond memories of the practice in Bromley where I worked, where we didn't used to leave an indwelling urinary catheter in.
Mm.
We'd drain them, we'd hospitalise them for 2-3 days, and then every now and then we'd have to put a UCath back in them.
Yeah.
And do you know what? They were much happier cats.
Yeah.
Much happier cats.
Yeah. I think I'd be a little bit worried about not leaving it in at all. I'm more one of those people that I'll be like, I'll leave it in for a bit. As soon as the urine starts to look a little bit better and the cat is happier, then I'll pull it out. Because I think you see so many of those cats that are so angry and pissed off because they've just got this catheter that's scratching the inside of their bladder and making them so uncomfortable. And I think actually it doesn't help a lot of the time it being in for longer than it needs to be. But as soon as they're eating and the azotemia is resolving, and especially if they start weeing round the catheter, because that happens so often as well, doesn't it? I'm like, well, get it out, it'd be fine. So, but I think it's just a conversation with the owners. As long as they know that there's a risk they can reblock whatever you do, then as long as it's an open conversation with them. And some people might prefer them not to be hospitalized anyway. But then equally, if you've got a cat that comes in and its potassium is 9 and its creatinine is, I don't know, 900, you probably do want to keep it in hospital anyway. In which case I'd argue, well, is it not better to just leave it in until it goes home?
The more comfortable, they eat better, they're more relaxed. And when you put the UCath, if you get to the point where you're like, I think we might have to replace that UCath, I would just give them a little bit of IV medetomidine. It would take me a few seconds and pop the UCath back in, drain the bladder, pull it out again. Now, look, the GP caseload is that particular clinic was all early presentations. I was really focused on no trauma. Like, let's unblock this cat. And then I know it's easy for me. I've done a million block cats, so I can really make a big effort. No trauma. Don't even be sucking on the UCath and causing trauma to the lining of the urethra. Super. If you can do it low trauma, then they're great. But obviously, if you've had an absolutely hellish unblocking, and you've only just got that UCath in by the skin of your teeth, you probably don't want to take it out. And so I think, and the trauma is obviously going to make the cat really unlikely to want to urinate. So but I think there is a caseload where you can do it well.
The last one is about our favourite topic, Brendan, teeth. So
antibiotics, that's another hot topic.
Yeah, exactly. So it's another one that we've been battered for on social media. But basically, it was just a systematic review published in JSAP.
But before you go into it, the social media thing, I was so wonderfully, what's the word? Like in huge respect for all these, particularly Swedish, perhaps also Norwegian vets that they get so many pyos there, don't they? Because I don't think they neuter as much. And they had so much experience and they were all saying how they don't do post-op antibiotics. And that gave me huge confidence to do a really good op, good flushing, no post-op antibiotics, pyos. And when you're listening to a vet that does it loads and they, you feel that this is a bit different from a study. I don't know, for me that, even though I'm all nerdy and scientific, for me that just makes me think, I feel okay now.
Yeah, it is interesting, but there's definitely the cases that I would think that fit more under that bracket. Like if I have a well pio that comes in and it's not severely neutropenic or massively neutrophilic, or it's, it's got no signs of any verging into sepsis or anything like that, then obviously I think I would be much more inclined to be like, yeah, it should be okay. But I think my case so tends to be they tend to be really quite sick when I see them.
Come on then, let's do this. You've got a good study about antibiotic stewardship for dentals. Go on. What is
Yeah,
this
so
one?
basically, it just sort of looked at some of the previous evidence, whether we should be using antibiotics in dentals, whether we shouldn't be. And basically, the long story short of the evidence is there's a major research gap for the common patient population that we see in terms of peri-procedural antimicrobials for dogs and cats in dentals, because it basically tried to see, is there any evidence of them getting sepsis or infective endocarditis or anything like that that could be associated with dentistry? And there's literally no links that they can find anywhere from the evidence that's actually come out there. So I think it's just really relevant because the majority of people in practice now aren't using routine antibiotics for dentistry, but I think there are still quite a few people out there that are. And actually, it just probably highlights that although we're saying you probably don't need them, it really does highlight a gap in the market to say there really should be a paper out there that proves that we don't. And that proves that there isn't really an increased risk of getting infective endocarditis or anything like that. We just need to get another paper out there that actually tells us what we should be doing. So yeah, it's just a massive gap.
I was talking about the cat today, wasn't I? The cat I did a dental on. I can't remember the context, but that one went on. Do you know what? Oh, this will really wind people up. I gave it an injection of Convenia. Oh,
Brendan!
Yeah. And I was proud. So I had to apologize to the nurse for doing it as well. But it's very, very rare. But you know what? This cat, when the inflammation around the mouth, it was a feline gingivitis stomatitis complex. So basically, the inflammation from its gingiva was going right into its buccal cavity and like round to the sides of its cheeks. And I had to take out a whole bunch of teeth. And I know when I've done them at post-op, the inflammation is still really apparent on day 3, day 10, day 7, because it's obviously there's a different process going on. It's not just now whether antibiotics is part of it or not. I've seen so many times the post-op will come and they'll go, oh, it's still really red. And then someone will give it antibiotics. And also this cat, it's got the most pain. You could never have gone near its mouth if you wanted to give it antibiotics. It was never going to happen. It was so painful. It was salivating, pouring at his mouth. It'd been going on for months. And I just thought, I'm going to give it a damn Convenia now because it's going to be on day 1. I'm going to get those. I did like a million extractions. His mouth was just like a bright red mess. It was like when we were doing the charting, every bit you touched just bled, like just immediately.
Poor little bugger.
I thought 1 Convenia now feels right because if I do a Sinulox or an anti-robe liquid or whatever, they're not going to be able to do it post-op. And I don't know what state this cat's going to be in because its mouth was so bad.
I think in theory for those, you should be using like those Chlorhex gels, shouldn't you really? I know that, and that's the thing. Like I think in an ideal situation, you'd use like NSAIDs and the Chlorhex stuff. But like you say, like if they're so painful, you're not going to be able to go rubbing stuff on those gums, are you? So yeah, I can get why you did it, 100%.
Anyway, post-op cat was doing bloody marvelously.
Good.
There you go.
Good old
controversial.
Good old Convenia.
I'm gonna get. I don't give me hate, people, because it's rare as I use Convenia.
Yeah, I'm gonna clip this up and put this on social media so you can have some hate. Because I'm getting it all at the moment.
Yeah, and you're getting it for vaccinating cats in the scruff.
My God,
how that you are representing like 50,000 vets in the UK, probably.
Honestly,
everyone.
Everyone in the US has told me that I'm a monster and that I shouldn't be practicing, and how clients shouldn't use me as a vet. But there we go. So
every week, there's more.
Exactly.
And just when you think it's going to finish,
I'm a monster. But yes,
you are.
Anyway.
Yeah.
Okay, so moving on from some of the more clinical chat onto the more juicy part of the podcast today, our chat with Bradley Viner.
So I was desperate to get Bradley on because I wanted to talk a little bit about the defensiveness that vets face when we know we've got to be covering our back over certain things, like the drug label says do this and we do that, and also kind of the idea is about what being a GP vet's about, because I think GP vets can be not valued for what they're doing compared
Mm,
to, let's say, a cardiologist or a neurosurgeon or whatever. But
yeah.
actually, that's not right, because a cardiologist and a neurosurgeon couldn't be a really good GP vet. They're different skills, but they both should be respected. So yeah, so
Yeah.
that's why I thought Badger Vine would be a good person to get on.
Yeah, absolutely. So have a little listen to us now. We're talking to him about how we should never be called just a GP vet, how GP could be looked at as like a specialty in its own right, disciplinary processes, and much, much more. So have a little listen. So for anyone who might not be so familiar with who you are and what you do, if you could, would you mind just giving us a little spiel, a little bio, if you like?
I qualified from the Royal Veterinary College back in 1978. And I worked in small animal practice for a year, and then I set it up on my own. I don't suppose many people do that nowadays after a year. Yeah, it was a different world, and I was very self-confident, perhaps foolishly, but I'm not sure it's something I'd recommend nowadays. But I started up a practice from scratch, and it gradually grew. In those days, you could only put up like a brass plaque, the specified sign outside the practice. You couldn't advertise other than a single column advertisement in a local newspaper. And you basically had to just sit back and wait for people to turn up. It gave me a good chance to decorate the practice. It also gave me an opportunity to learn how to type, which has been really useful. But gradually the practice grew, and my family grew, and the two became incompatible in terms of the house that we're inheriting. So we moved out, and I established a branch practice in the house that we moved to, and discovered that actually working and running a practice when you're not actually living there is quite different to when you're living on site. But anyway, the practice grew, and eventually we reached 5 sites, 5 veterinary group, Northwest London. Had a son and a daughter. My son is now a veterinary surgeon. His wife is a veterinary surgeon. But my daughter, she's an educational psychologist, and I have 7 grandchildren, so that's kept me pretty busy. Early on in my career, I started doing a lot of TV work and radio broadcasting. I was the Luke Peter vet for quite a while, the Big Breakfast, and then many of your listeners remember that. Richard and Judy up in Liverpool, used to go up there and broadcast. And I had a regular radio program as well on LBC Radio in London, which went out basically early in the morning, but at one point it was going out 7 days a week, called Petline. And then the focus of my work changed. I got involved with a group of vets who were very keen to develop a postgraduate qualification in veterinary general practice. Like doctors are expected to, as a routine, to do a qualification if they want to become a GP. But as a profession, we've been very focused on, if you want to become more advanced, you have to become more specialized. And really, what I became very passionate about was changing that paradigm to being a general practitioner is a really important job. It's a really skillful job, and there are a whole set of skills that you can develop that are actually quite different to skills that you need to be a good specialist. The fact that we don't live in a perfect world, we can't always carry out the ideal tests that will be carried out for a particular condition. And the skills that we need are in terms of communication skills, team working skills, personal development skills, become really important. We wanted to provide a framework for this qualification that would sit alongside things like a dermatology or orthopedics certificates and so on. So there is, in fact, now a certificate in veterinary general practice. I can't say it's as popular as I'd like it to be, but I do think there has recently been an increased interest in the skills that you do need to be a GP vet. And you can now become an advanced practitioner in veterinary general practice. I decided that the most valid way of actually measuring how effective you are as a general practitioner is to measure outcomes. And that's how I became interested in clinical audit, which is all about using the measurement of outcomes as a tool in order to continually improve your performance, which is really my main hobby horse. And I went on. I caught the academic bug, so I then went on and did a doctorate with Middlesex University into the introduction of clinical audit into veterinary practice. And I also found that wanting to bring about change, it was sometimes frustrating being outside the Royal College structure. So I stood for election to Royal College Council, possibly helped by a regular column I wrote in Veterinary Times called Reflections, which was quite sometimes quite a light-hearted look at veterinary practice and the challenges that we faced. I stood 3 times, 3 4 year sessions, and I eventually had the honour of being elected as first of all, Treasurer, Junior Vice President, and President. And at the end of that, July the 7th, it was in 2017. It was a big day for me because I both fell off the end of the ladder at Royal College Council. I decided not to stand again for re-election. My term as Senior Vice President had finished and decided they'd all heard enough of me. And I also, on that day, the sale of my practices went through. I sold my practices to the mayors, but I did carry on working for them. I carried on working, not clinically. I also was independently appointed after a year or so off our college council to be chair of the preliminary investigation committee, which is the committee that filters all the cases that are in terms of professional conduct concerns against members of the profession, which is an interesting job. I wanted to do it because I feel it's a really important job. I think that when most of vets think about the Royal College, they do tend to think about the disciplinary process and the fear of getting caught up in it. And I think that having vets who understand the challenges of general practice and the real world in which we operate, and trying to work that system that is fair and efficient, both for the veterinary surgeons on one side and the complainants on the other side, who sometimes are veterinary surgeons, but of course more often are members of the public. It's a very interesting, very challenging job. When you do tend to see the darker side of veterinary practice as well. Of course, you see when things go wrong. But actually, we all make mistakes, and the system isn't there to penalise people for making a genuine mistake. If you make repeated mistakes and don't learn from them, that's a different matter. But there's an element of luck as well. If you get a litigious client who is determined to make life difficult for you as a veterinary surgeon, then unfortunately the complaints process can be quite a good way of achieving that. But ultimately, the vast majority of cases that come our way are handled basically behind closed doors. They don't go into the public arena. Only a small percentage, 2-3% of cases, actually go to the ultimate disciplinary hearing, which obviously, as we all know, which is where vets can be struck off.
When I'm hearing all of that, part of me thinks that everything you've done in the last 10 years would feed back to how you would run a practice in a different. Would you look back now at how you ran your practice?
Yeah, I wouldn't say differently. I feel very fortunate, really, that the turn my career took and the way it developed fed into me being in practice for nearly 40 years and then stepping back from being a clinician, but actually doing work that was still challenging and interesting. I've had a very interesting and I think very fortunate career. I suppose an illustration as well of how when you start out on a veterinary degree, you don't really know where it's going to take you. You can be a practitioner through your whole career. And the one thing I hate hearing is when someone says, I'm only a GP vet, because that's such an important role. And one of the things that I was very keen to help try and develop within VINER was a way of valuing and rewarding and maintaining people in good vets and at the front line in general practice, and not assuming that in order to become more senior and better remunerated, you have to go up that ladder and become a clinical director and maybe a regional director and all the sort of superstructures that we've now what's available to us within corporate veterinary practice, or even necessarily a partner, but actually just being a bloody good clinician is a really worthwhile thing to do. The profession really has to look at how it keeps good clinician motivated and within the profession, rather than having them burn out in their 30s and just leaving to do something else, which again may be a good career path for them.
It's that thing where it's GP is almost a specialty in its own right, but it's like a specialty of breadth rather than a specialty of depth, if that makes sense. So instead of being really, really good at one particular thing, you're very good to a slightly less detailed level at everything, because you have to know enough neurology to know what you're referring to a neurologist. You have to know enough ophthalmology to know what you're referring to an ophthalmologist. So you have to be pretty good at everything. You just don't have to be absolutely excellent at any particular specialty, because it means that you're good at everything. And I think, like you say, people underestimate the value of that a hell of a lot. And that's partly why we started this podcast as well, because we think being a GP vet can be really bloody difficult. It's not easy. There's a hell of a lot that we have to know, and a hell of a lot of challenges that we have that perhaps a lot of referral surgeons or referral clinicians don't deal with. So it is a specialty in its own right.
The college has been looking at it again, and they are moving towards, and I'm trying to resist it, but now from the outside rather than the inside, towards having what they will call a specialist in veterinary general practice. I suppose you could argue it's just semantics, but to me, I think the term specialist, when you apply it to general practice, is perhaps a dangerous one, because exactly as you pointed out, it's being a generalist, which is the whole essence of it. And becoming, let's say, concentrated on neurology is fine. We need neurologists, but the skills that you need to become a good advanced practitioner or specialist in neurology are to some extent different that you need to be a really good general practitioner. The other thing that we're talking about is when things go wrong.
Yeah.
And disciplinary or court processes. I think it all comes down to communication, comes down to consent, and it comes down to record keeping.
Am I right in thinking, Bradley, that generally they say that as long as you do anything that any other reasonable vet would do, that most of the time you are pretty okay with whatever ends up happening, because as long as you're doing what any other reasonable practitioner would do, then in theory you should be covered.
Yes. Doesn't mean to say you won't get a complaint, and it's possible that complaint may then require you to respond to it and to deal with it. But from the Royal College point of view, and the disciplinary process, it doesn't deal with negligence. So if you make a mistake, then that is potentially negligent, and there may be compensation that needs to be paid, and that's something that the VDS would normally assist with, and if they asked to get involved in it. And that basically is performance that is below the standard that's expected. In terms of professional misconduct, it's got to be significantly worse than that. It has to be what we call far below. So it has, basically, you have to do something clinically that is so bad that no other reasonable vet, as you've said, could be expected to do something similar in those circumstances. And that it is actually a pretty high bar. Quite frustrating for complainants, because although we do keep saying to them, we can't help you with negligence if you need to go through the court system, or of course there is the VCMS, the mediation service, which is free, and although practices aren't obliged to interact with it, most practices do. But as I say, in terms of professional misconduct, it's got to be really bad, and there would normally be an expert that can be called in to give an opinion on that as to whether it could be defined as being far below. And so we get quite a lot of stick from the general public about that level at which the college will intervene. For better or for worse, that's the legislative framework within which we work.
Charlotte, can we talk about your ketamine problem as well? That was so funny.
Oh God. Well, I don't know whether this is going to get me in trouble with Bradley.
Actually, yeah.
Well,
Oh no, he's going to visit you
no.
tomorrow and sort it out.
Yeah. Well, basically, it was really scary. So when I was about 2 years qualified, I had a phone call randomly from a police officer. And he said, "Oh, I'm PC such and such." I was thinking, "Oh my God, what have I done?" Anyway, he'd gone to one of the practices I'd been locuming at the year before, and had said, "Do you remember why you used out-of-date ketamine?" Anyway, long story short, it was a really, really aggressive dog that had been imported from Romania. The owners couldn't even get so much as a lead or a collar on it, let alone get near it without it biting them. So I ended up having to go out on a home visit to put it to sleep. And I mean, it was horrible. It was like dog catch pole, push it to the floor, whack as much sedation as I could to get in it, to even be able to get near it, to muzzle it. And the branch practice that I was locuming at had next to no sedation. They had Domentor was what I had to use, and a bottle of out-of-date ketamine. And I was like, well, it's a human safety issue. I can't just rely on Domentor. Like, I need something else to give it as well. So I gave it out-of-date ketamine and I put it in the book. And I wrote in the notes what I'd given. But anyway, he pulled me up on it because I'd used out-of-date ketamine. And he was like, to make you feel better, we're not going to see it as a criminal problem because you put human safety first. And I was like, well, bloody hope not. I don't think I've done anything criminal. But he was like, I am going to have to report you to the RCVS because I feel you've gone against your code of conduct. And I was thinking, oh my God, what else was I supposed to do? You know, when you think, I don't want to get bitten. I don't want the owners to get bitten. I don't want any of my staff to get bitten. And it was horrible because for about 6 months, I was terrified I was going to get struck off. And I mean, either he didn't go to the RCVS or the RCVS looked at it and thought, we're not going to do anything about that. So just never contacted me. I'm not sure which it was, but I never got a phone call or anything. But it was horrible. I panicked for about 6 months thinking, that's it, I'm done. I'm not going to be a vet anymore. It's horrid.
As I said earlier, it's really important that we try and make the process both as fair but also as efficient as we possibly can. But it does take time. And that's why if you can take steps to avoid getting complaints against you, then obviously it makes life a lot less stressful for you. Cases that come into college go through a process where, first of all, a case manager will look at it and see, like you were saying, whether there's actually any potential for professional misconduct there. And if there isn't, then the vet will not actually, in most instances, even be aware that the contact's been made with the Royal College. Then there's what we call stage 1 PRC for potential cases that will look at it. There are 3 members. Vet, 1 lay member, a third you can be either a lay member or a veterinary surgeon, and they will look at it more formally. They often then will contact the veterinary surgeon, although it's still possible that a case could be closed at that level without the vet even knowing. And they will decide whether there is a potential for serious professional misconduct. And if they can't say that there isn't, then they pass it on to the stage 2 committee, which I chair, which then has to make sorts of decisions as to whether it progresses. It may well involve taking statements from people involved. It may involve getting expert witnesses and so on. But there is a kind of a stage process which is filtering down to, as I say, the ultimate, which fortunately in terms of percentages we don't have to resort to very often, which is where we refer a case to the disciplinary committee. We have also got a new stage in the process called the charter case committee, which is for cases that are deemed to be serious professional misconduct, but in our judgment of the professional PRC committee, it's not likely to result in a striking off by the disciplinary committee, because they can put other sanctions in place. And the charter case committee can give a warning, a formal warning, and it gets recorded in the register. I believe it's for 6 months, and it gives for 6 months. So it's kind of on their record formally. So it's in the public domain, which if advice is given just at the PRC level, it's still confidential. But that's a way in which cases can be dealt with more informally than the terror of going through a full disciplinary committee hearing, which is something that no veterinary surgeon wants to go through.
No.
So in the anonymous case of a young female vet that used out-of-date drug for the benefit of human safety, would you be...
No, I'm
I
sorry,
think
Charlotte.
she's struck off.
You're going to hell as well. But it's much more fun there. You can keep chatting to Brendan there. No, I mean,
Yeah,
common sense does rule. As I say,
Yeah.
that, the case managers are encouraged to deal with cases with common sense. The veterinary surgeons who are involved throughout the process and the main members understand about general, particularly where you're dealing with something where, as you say, there's a risk to your own safety and public safety. Then of course you can override a data sheet, but
Yeah.
it's much better to record why you did it contemporaneously than try and explain it 6 months or a year later retrospectively, both in terms of you being able to do it more accurately.
Thank you very much, Bradley, for coming on board with us today. We've really appreciated you taking the time out of your busy schedule and taking you away from the sunshine as well. It's lovely out there. So thank you very much. We really appreciate it.
Thank you very much for asking me. It's been great fun.
Thank you so much to Bradley for joining us on the pod. We've really enjoyed our chat with him and we hope you did too.
Yep, I think we rudely interrupted his tennis game, actually, because I phoned him up and said, Bradley, you're meant to be on. And he was like, I've just finished playing tennis. So, anyway, but he did it. So, quick roundup time. We've covered loads today, from needle caps in your mouth, and sorry if I got a bit emotional about that, to regurgitation in BOAS patients, bleeding during bitch spays. Obviously, our meeting with Bradley VINER, cats prophylactic antibiotics.
We hope as ever you've enjoyed listening, and remember to get in touch if you have any comments or suggestions to help us improve these pods for you, any topics that you particularly want to cover, etc. So remember, you've got the blog, our WhatsApp number and the socials to contact us through, so please do get in touch.
Yep, absolutely. But for now, thank you for listening. Next Sunday is our day of rest, but join us the following weekend for our next 2-week takedown, where we'll be discussing some new advances in osteoarthritis and much, much more.
We're looking forward to it. Until then, it's bye from me.
And bye from me. Take care. This podcast is intended for licensed veterinary professionals and is provided for educational and discussion purposes only. Whilst it is publicly accessible, it is not intended as advice for pet owners.
The views shared are based on our own clinical experience and interpretation and do not replace individual clinical judgment. We accept no responsibility for decisions made based on this content, and all cases should be assessed on an individual basis.
Any references to medications, treatments, or products are made for educational discussion only and are not intended to promote or advertise veterinary medicines to the general public. Veterinary medicine should only be used under the direction of a prescribing veterinary surgeon and in accordance with UK veterinary medicine regulations.
This podcast may include paid partnerships or sponsorships. These do not influence our clinical opinions, and any sponsored content will be clearly identified.